start to get invested in this, not invested, they are invested, but I think concerned about this. We're starting to see the federal agencies start to look for information. And I'm talking about the information that I'm looking for, which is behind the scenes information. Not just the reports, but where all the contracts with all the vertically integrated companies and the contracts between everybody in the healthcare chain. Representative Corbett, would you mind? I give this as an example of what's going on across the nation. Just click if you. No, it's just a screen for folks to see. It's actually somewhat relevant, but it's not the answer. We saw this. This is excerpts from United States Senate Finance Committee. It was a bipartisan effort by Senator Grassley and Wyden, and it is actually regarding, it was specific to insulin drugs, but I thought the comments in it were particularly interesting, so that I want to make sure that the committee understands the bigger picture and of what we're looking for here in Georgia. But I thought this section, this is page I think 65 from the report, but I think this was particularly there, and it's in regards to PBMs have been subject to a great deal of scrutiny for their role in rising drug prices. Although they're the centerpiece of the drug pricing negotiations, their practices and business relationships remain largely opaque. As discussed above, the lack of transparency is due in a large part to the confidentiality of the contractual relationships PBMs have both with health insurers and drug manufacturers. I'll stop there and expand. Y'all saw slides from last year. We're seeing a vertical integration in which the insurance companies own the PBMs, they own the benefit manager, other benefit managers. They're even getting into the role where they own the providers, whether that's the specialty and the regular drugs, or quite frankly, if you're on the health side of this, the non-prescription drug side of this, you better watch out, because they're getting into health care. And you're going to see that everything is going to start steering towards their assets. They control the contracts, and they'll end up steering, not only as they've done in prescription drugs, but they'll do it on the healthcare side. What's interesting is the House and Human Services, the Office of Inspector General found that this lack of transparency raises concerns that sponsors may not always have enough information to oversee the services and the information provided by the PBMs. And then 340, that's a line that should have been taken out as I copy it. The industry continues to fight efforts to bring visibility to its operations. Likewise, PBMs were not fully responsive to the committee's request during the investigation, variously failing to timely produce documents and produce all of the requested documents, or produce documents that were not fully unredacted. To the members of the committee and those listening, last year I did an extensive open records request for the state's contracts. And again, likewise here. It took months to get, and when I got it, it was redacted. Next slide. This is an example, and I know it's still on the prescription drug benefit side, but we're not addressing cost. We've got a artificial, if you will, manufacturer's retail price on healthcare. We focused on prescription drugs, but I think it's likewise or similar to on the healthcare side. But this was talking about a specific provision or paragraph in this same report, okay? And I think it's interesting because I think it's going to lead the committee to, if you really look at this, you had Novo Nordisk that were talking about the price decreases after feeling outside pressure from after its 18 list price increase. So the company began to face pressure from payers, the media, and Congress to reduce the price of its insulin drugs. And then in May of 18, the company, I guess the board debated whether it should reduce the list price of its insulin drugs by 50%. 50%. After a string of news reports detailing how patients were struggling to afford their medications, the company believed that a 50% cut would be a meaningful reduction to patients, significantly closing the list to net gap to head off negative press attention and release the pressure from congressional hearings. However, the company was concerned that a list price reduction posed a significant financial risk to the company. First of all, what's the difference? Okay? What is that list to net gap? It's basically the artificial, if you will, WAC or WAC or wholesale acquisition cost, which is an artificial sticker price, and the net gap is what they get after they give the rebates to the PBMs. 50%. So I want to change your thinking for a second. Is the cost of insulin really what it is today at that price, and what of all our insurance contracts or have them at, even though we can't see them at this artificial price? In this case, this gives you evidence that the real cost of that drug from the manufacturer is probably about half. So we're really looking at just, again, little here now nudges around the end. Are we really going to get to the underlying cost of health care? It is noteworthy that the company's primary concerns were retributive action from the other entities in the pharmaceutical supply chain, many of which derive payments that are based on a percentage of the drug's wholesale acquisition price. So if you're on a commission basis or you get a percentage, what would you rather get a percentage of, the actual cost? Or would you rather get a percentage if you're making your money on some artificial price? I also want you to note what our patients and the beneficiaries of of the plans pay. Co-insurance, deductibles, okay? All of the money that comes out of the patient pocket is based on what? It's based on the artificial list price. Guys, we can keep beating around the bush here about these things. We can really get at what really is going to help Georgians and companies as they continue to try to strive to provide good health care coverage and the patients that are and to the patients at a reasonable price. Last slide. I'll leave you with this, and this is the slide that we showed earlier in the first hearing. This is just for the state health benefit plan. And if you look at the projected expenses, they're going up, $300 to $400 million a year. It's a never-ending increase. But yet we hear time and time again that the companies are here to help lower the cost of health care. The reason why we had this bill, and we had one 991 last year, was so that this body, okay, could help look at and look into the issues that are surrounding the industry. The same questions that are being asked at the federal level. Georgia has always led, and we will continue to lead, and that's the purpose of the bill. I will congratulate the industry. They've done a good job of demagoguing, asking questions, planning questions regarding what this bill does, and really, I think the intent was to go back to 991 from last year. So with that, Mr. Chairman, I'm going to ask that we table these two bills. But I will tell you, the work has just begun. If you think that it's over, you wait. Next year, next session, we'll be back. And we're going to be back, and we're going to educate people on what the real issues are and where the real cost of health care lies. And I guarantee you, with the reports and the things that are coming out from the feds, plus what we're uncovering, I think everybody will understand this a little bit better. We need to move to true market health care. It's based on real cost, and it's not based on proprietary and hidden confidential contracts of Wall Street's top 30 and 40 companies. Mr. Chairman, I'll ask that the committee table these bills.
Is there objection from the committee? Hearing none, we'll accept the author's request to table these two bills. They still are live for, well, the remainder of this session and as well as next session to be removed from the table at the appropriate time. All right. Thank you, sir. We do have another bill on our agenda today that we are going to address, House Bill 164. If bill author would come on up, we'll I know we've started a hearing on this. If you can give just a really brief. Yes, sir.
Would you take a question on previous bill?
Yes, sir. Sure. Hang on, just push your button there.
I did. It just didn't light up.
One more time.
Yep.
Is that you?
That's me. Thank you. I appreciate the presentation. One question I had is, we look at this, when those are put out on competitive bids, is there collusion in the industry that keeps this from somebody being able to bid at a lower price and take this into consideration? You would think with all of that going on that somebody would come in, Dollar General will open up down the street or something. Is that, when I don't understand how the bid process goes on this, but is that a consideration too, as to how the bids are done? And I don't want a long answer. I know we want to move on.
No, Chairman, I think you've touched on something. In our research with the RFPs that went out for the state health benefit plan last time, we saw provisions in there, and you can write an RFP, as you know, that you can pretty much dictate, a limited number of vendors who would be, meet those requirements. We started to see some of those including the fact that they needed to own their own specialty and mail order pharmacies, which, as you know, is in direct violation of what this General Assembly has done over the last couple of years in regards to steering. So we had an RFP out there, the way I read these requirements, in which it required the PBM to actually own their own specialty and mail order pharmacies. Okay. So we've heard in past testimony from independent or other types of PBMs and folks that are trying to get in this, as they come up with innovative and new ideas, they want to get into the market. And I think competition is always good, isn't it?
Yeah.
But again, I think everything is written at this point towards basically capturing a group of probably the top 6, if you will, Wall Street owned, healthcare companies or their PBMs. And so I think we're going to look into this. Okay. And I appreciate your question. It's it's very spot on.
Thank you.
Thank you, Chairman. And thank you, Chairman Knight. Before we begin on House Bill 164, we had offered what I believe the author will approve as a friendly amendment. If you can get your copy of the bill, LC 345758S, working on the right one. On line 45, the omission would be state health care or, and then down on line 65, the entire section that discusses state health care benefit plan or state health care plan. So 65 through 73 would be removed. And so I know this bill is seeking to attack, or I'm sorry, to at least address a portion of what Chairman Knight has discussed, and obviously some things have to be done in bits and pieces. So tell us about your bill, if you're, and if you're acceptable to the amendment as proposed, that we'll make the official change at the appropriate time.
Mr. Chair, if I could understand, you said, I just want to make sure you're redacting 65 to 73? and
No, no,
replace-
uh,
No,
Correct. Line 65 through 73 would be removed.
correct, and then what was the other change?
On line 45, 3 words would be removed, which is state healthcare or.
Okay, thank you.
Thank
Sorry
you
about
for the
that.
No,
clarification.
you're fine.
Representative Douglas, go ahead.
Thank you, Mr. Chair. I didn't mention the first time that I came before you that this is a great bipartisan bill, by the way. And I wanted to mention that this time since one of my chairmen is in the House of one of the best committees in the House, Chairman Cooper. Members of the committee, I just wanted you to look at House Bill 164, and you heard the testimony a couple of days ago about the bill. It gives rebates at the counter for prescription drugs. And I thought about this bill over when we were out for the pandemic about what could I do for my constituents in House District 78, along with the state of Georgia, considering that everybody was going to be looking at life a little differently. And what I came up with is, how can I help them more coming out of a pandemic? And I started to think about them catching COVID, them coming back from COVID, what would be necessary for them to take a burden off? And I thought about prescription drugs. And so this is not my swim lane, so I contact the professionals to get information about it. And that's how this bill came about. And that's basically the overview about the bill, is just basically having an 80% reduction on prescription drugs at the counter. And so this would really help the people who have been on COVID, the people coming off of COVID, and just the people that have to have medicines on a day-to-day basis, medicines like insulins that keep rising, the price keeps rising. And like the chairman said earlier, we don't know the real cost of the medicine. So the price they give, they don't really know if that's the correct price or not. And so that's how we got to this point. And Mr. Chair, I don't know if you want to.
I think that's helpful. I know you did give us a handout to the
Yes.
committee, and I didn't know if you had someone signed up also to speak in reference to the handout or in anything else, but.
Well, I did initially, but we have gone in a different direction. So
Okay.
they won't be needed at the time, but I would just like to, if the committee
Sure.
and the chairperson is amenable to moving it forward with the amendments, I am favored with that.
We'll look into that at the appropriate time,
Okay.
potentially. I will say, we do have some questions from members of the committee, which we'll,
Okay.
for the presenter. Chairman Knight.
Chairman, Representative Douglas, I want to applaud you for what you've done. I think you've tapped into a small part of a vast problem. And certainly we look at issues like insulin, and of course there's other things that are out there regarding, cancer and oncology and autoimmune issues. I mean, so, the issue is vast. Certainly insulin's a high profile part of this equation. And I want to applaud you for what you're doing, because you're starting to tap into a little piece of a bigger equation. And I hope you see that from what
Yes.
I just talked about.
Absolutely.
But I'm curious, your handout is coming from pharma. And I've talked with these guys, and I think we've got a lot of issues in the room, but as far as where the blame is, but again, back to that slide and back to this report from the feds, from the Senate. What say you in regards to the fact of cost and the fact that we had one company that was going to slash its list price 50%? So if you apply that half, 50% to the example here, what does that really do to cost? Not only cost to the patient, but cost to the plan. Okay?
Well, I'm not a specialist on this.
But in general, you
But-
see where I'm going here.
I can phone a friend who can help answer that question, if the chairperson allows that.
Sure, certainly.
Okay. Zach,
Oh.
did you hear the question?
So we're joined by
Zach, are you there?
speakerphone, is that right?
Yes.
Yes, I'm here, Representative.
Okay. Did you hear that question?
Could you repeat that, please?
Can you repeat the question?
Well, I mean, as you follow this chart, which is hypothetical, but it's at a list price, okay? The WAC, the WAC price. What if we just do away with that? In other words, we've got one of the companies that was a major producer of insulin, and they were on the inside talking about that, saying it would be the right thing to do. In other words, you go from that back down to a more realistic market-based cost of what the actual product is. What would be the savings there? And what would be the savings not only to the patient or the beneficiary, but what would be the savings to the plan? Okay? That's my question.
Did you hear that, Zach?
I did, thank you. And it's a great question, Representative Knight. And, I think that that's something that, frankly, the previous administration, the Trump administration, had looked at doing early on in the administration. And I think it's still an option that could definitely be considered. There are a lot of business considerations to take into account from the plans, the insurers, the PBMs, the pharmacies, the manufacturers, the wholesalers. There are a lot of things that go into determining a drug's price, both the list and the net. And as you mentioned, there is a big gap between the list price, the WAC price, and the net price. And I think one of the great point that you make, and I think that really the solution that we need to get to right now is figuring out how to get that money that's in the gap to the patients who really need it. And I think that this bill does a good job of that by getting at least 80% of the rebate to the patients at the point of sale. And in case anyone doesn't know, my name is Zach Poss, and I'm a director of state policy at Pharma.
Follow-up question, if I will, Mr. Chairman. And I guess a question back to Zach, if you will. But you said, to get all of the pricing that's in that gap, in other words, that artificial manufacturers, or in this case, WAC, as y'all call it within the industry, if that is not actually the cost of your drug, okay, and that's what you're giving back to in the form of rebates. My question is just as in your discussion, or the internal discussion within this particular drug manufacturer of insulin, why wouldn't you go back and you go ahead and just say, hey, this is our cost of the drug. It's a fair, more actual cost. It's reflective of the market cost of this drug. Why wouldn't you do that? If you're concerned about the patient and you're concerned about plans, wouldn't that drive the cost automatically down to the plan and patient?
I think you do make a good point. And one of the things that unfortunately we cannot control is, we do set the list price. That's true. But we can't really control, except through the rebate, how plans and PBMs decide to cover the drug. One example that I can give you is in the hepatitis C space. There are a couple of drug companies that produced hepatitis C drugs. One of our companies, Merck, came out with a drug that had a significantly lower list price for their drug, and consequently a smaller rebate. And the PBMs didn't want to carry that drug on their formularies because they were getting a lower percentage rebate. And so that drug saw significantly reduced sales. So in some ways, the rebate it's a good question of, what can be done to actually reduce costs for patients. And I think that in the current market system, the approach that House Bill 164 takes is the current best solution until there's some change on the federal level to the way that the markets work.
Chairman Houston.
Well, I appreciate you bringing the bill, because I think right now the consumer is getting nothing, and this would give them 80%. And coming out of this environment, we need something to boost the economy, and I think this would really boost it. And we can't, I know we can wait till next year, but we need to do something now.
Author agrees, I assume.
Absolutely.
Thank you, Mr. Chair. Representative Douglas, the thing that I took away from your phone a friend was that you're advocating a policy that aligns with that of the Trump administration. Is that correct?
Are you sure you want to? Could you say that clearly, Representative Douglas, and we'll entertain a motion.
If it's,
Thank you, sir.
I do have a response. I didn't say, and I've never been an advocate of all of the policies, just like here at the Capitol. We agree on 90% of what we do. It's just the 10% that we have a problem with. And so that was one of the things that was great and came out. And so I applaud him for that. I didn't say he was,
Let's just
everything he
leave
did
it
was
there.
great,
Let's
but
just, I'm
we're
gonna
gonna leave it right there.
I'm going to turn off your microphone now.
gonna-
We do have some we do have some that want to speak to the bill, unless there's any other committee members that have a question for the presenter. Yes, Chairman Jones. Which number are you? 11?
I'll just use my voice.
Go ahead. No, you're good.
To my bulldog friend,
Yes, sir.
he counts me as his favorite gator. I know
It's
it's
a
an
short list.
oxymoron. Yeah. It's a short list. But in all seriousness, I love what you're trying to achieve. I tend to be that guy who loves the aspirational, who loves the vision. I'm trying to follow between your handout and then the bill. Is there a simple 60-second explanation of why the 80%? And then how that's going to be paid for? Because at the end of the day, there still needs to be something in there in terms of margin. But I'm just trying to grasp it. And if I missed it from the last hearing that I missed, I apologize, Mr. Chairman.
I could.
Go ahead.
Oh,
Go ahead.
I
Go
can
ahead,
tell you
Chair.
what, I asked the same, it's a great question. I think I asked the same question. It actually harkens back to the medical loss ratio. That's an acceptable administration and overhead fee for an insurer for medical expenses. For individual plans, it was 20%, and then 15%, I believe, for group plans that's in the Affordable Care Act. And so that was recognized as a reasonable profit, if you will, overhead and profit that an insurer would take. And I think so. I believe he just matched since a lot of these will be individual plans, since we're exempt from ERISA and the large group plans, and we've eliminated the state 680,000 member plan. I think that's where the 80%, I believe, was the correct appropriate administrative expense.
Okay, perfect. Thank you. I appreciate that. Thank you.
We do have others to speak on the bill, and if the committee have no other questions for the presenter, we'll move on to them. And first, I believe Jesse Wethington, I believe you can come up, just introduce yourself.
Yes, thank you, Mr. Chairman. Good afternoon, Mr. Chairman, members of the committee. My name is Jesse Wethington. I'm here today on behalf of the Georgia Association of Health Plans, which is the trade association of the commercial health insurance benefit industry. We respectfully oppose House Bill 164 as written. I will not rehash my testimony from the other day when the committee heard this, but our concerns remain the same. In terms of 80% point of sale rebates, my question would be, how do we calculate that number, 80% of what? Additionally, I would remind you that a lot of these are adjudicated up to a quarter after the fact, depending on market share. The companies negotiate an agreement, and then we want to see how we did. And so the rebates are finally, what that amount is for that quarter is not determined until after the fact. So we're going to have trouble calculating this amount at the pharmacy counter. Additionally, what I would say to you just briefly, this bill is all about the relative market share of a generic drug versus a brand name drug. That's why the Pharmaceutical Research Manufacturing Association is supporting the bill. Rebates are used to influence the preferred or non-preferred status of a drug on a health plan or PBM's formulary. Our contention is that if there's a generic equivalent available, that is the FDA is deemed to be therapeutically equivalent, and there's no other issues for the patient, we would prefer for them to utilize that drug. This General Assembly has already addressed issues like step therapy. So the Chairman Cooper has dealt with that in previous years. And again, just wanted to remind you that the consumers are currently getting the benefit of these. We're just passing them on through premium discounts every month versus rebates at the point of sale. So those are our issues with the bill, and we would ask for your respectful consideration and not support House Bill 174 for those reasons. 164.
If you're okay with a couple of questions, do you believe the rebates are an effective way to change the formulary that a PBM
It becomes a
uses?
negotiating tool. I mean, it's really like how much of a rebate does the manufacturer want to give to the PBM or the insurer to increase their market share. It works the same way in Medicaid now. It's how you get on the preferred drug list.
Chairman Cooper.
Okay, so what you're saying, how much the drug manufacturer wants to give to the PBM so anyway, they're buying their way, they're having to pay these people something to get them to carry their drugs.
Right, versus the generic equivalent, which we would almost always prefer if they were therapeutically equivalent.
So you've got a
They need to justify the 8 to 9 times as much list price that they're charging for the same drug versus, a generic equivalent we can get to a patient that costs $5 or $6. So the rebates are a way where they actually make their brand name drugs affordable for our members versus the generics.
rebate makes it affordable.
It sounds like, I don't know if you got a chance to look at the handout. that
Double
there's
Pharma
any
did not give me
form-
their handout, Mr. Chairman.
Okay.
It sounds like the insurers might be on the same side as in favor of this bill and in favor of the consumer.
We feel
And
like
who wants generic drugs and the lowest cost drugs? It sounds like there's a PBM in the middle, though.
we would like to continue to be able to pass on the discounts in the form of reduced premiums versus at that member's point of sale.
Chairman Knight.
Well, I guess a couple of things. I know some of these drugs that we're particularly talking about in this study, if I remember correctly, there probably weren't generic or a lot of good generic options available. I think I've read this in this U.S. Senate study, okay? So if that's the case, there is no option. And again, I go back to a comment of your comment that the manufacturers are buying their way onto the formulary. I would quite frankly somewhat say that's true. But if they're paying for it, somebody's getting it.
Or they could be
And-
insisting
and-
on it, I guess.
No, they're not insisting on it. I from what I've read, Mr. Chairman, ultimately the formularies belong to the insurance or the PBMs
PBM.
that make it. So, ultimately that control of that contract is there. But it sounds like you've got two that are playing a game there. And if you've got a willing, somebody's willing to pay it and somebody's willing to receive it, don't do well, that doesn't say much for both of them. And I want to take this committee back to, what is the primary purpose of what we've been told a formulary is for? It's supposed to be for therapeutic purposes, right? Everything we've heard is these formularies are based on the experts and the therapeutic. Number one reason is the therapeutic, how these drugs help the patients. But in the case that I've heard today, it doesn't seem that way. It seems like there's an additional issue that's out there, and that's the money that's changing hands. I don't know if that's, how do you speak to that?
Well, to address your question, Chairman Knight, if you'll notice, I said that we would prefer the lowest cost therapeutically equivalent drug.
All right. I don't see any other questions right this minute. We'll thank you for your testimony.
Thank you, Mr. Chairman, members of the committee.
Cash Trivedi, come on up.
Thank you, Mr. Chairman. Castrovetti, PCMA, the National Trade Association. For the pharmacy benefit managers, as I mentioned earlier this week, we respectfully oppose House Bill 164. Rebates, for the most part, are passed back to the plan sponsors, which keep premiums low. Generic drugs typically don't qualify for rebates. Only competitive branded drugs do. With that, I'll conclude. Try to answer any questions you guys may have.
What was his last statement, Mr. Chairman? And I'm sorry, I didn't hear, I was reading. You said the last part of your statement.
So branded competitive drugs typically have the rebates on them, not your generics, which most drugs dispensed are generics.
So there's no rebates on generic drugs? Is that, just to clarify?
That's my understanding. I can give some clarification and get it to you.
Thank you very much. Skin Edge, you were here for the other two bills, is that right? All right, and Dorothy, is that Glasser? Oh, also by speakerphone. Thank you for doing that. We're running out of rooms to have Zoom meetings in, so we're doing our own. I think it worked well, though.
Hey, Dorothy,
You're
you've
on.
got the Dr. Newton Special Committee here, so I'm going to put you on speaker.
Thank you.
All right?
Go ahead. Thank you for being here.
Dorothy, go ahead.
Thank you. Thank you so much for letting me speak today on this very important issue. I've been listening to all of the comments, and I just wanted to say that we must not forget that we are also talking about the largest population, which is our chronically ill population. The RxMH Georgia Coalition is over 41 health-centered members from patient organizations. We've been advocating for years that the rebate money, which is what it was created for, goes back to the patient, not to the insurance plans, not to the pharmacy benefit managers. We're talking about usually cutting-edge medications, innovative drugs that make the difference between being wheelchair-bound or walking, that make the difference between being disabled or productive in our community. There are patients that these drugs make the difference between life and death for them. Those are the patients that we're talking about. We had in our last session Representative Bentley speak about her husband who has survived COVID and now has chronic conditions. These are the drugs that make the difference for people with chronic illnesses to be able to survive. These rebates, if you want to talk about whether the drugs should be at a more reasonable price to begin with, that's a discussion for another day. That's a discussion to revamp our entire manufacturing system. What we're talking about today is, are the patients going to get the discounts that were created for them so that we could ease the financial burden of them taking these medications that make a difference for them in their lives? Not only the quality of life, but for many, how long they live. This should not be negotiated. These rebates were made to be given to patients for that one purpose, and at point of sale at the pharmacy counter is when they should be able to receive the rebate, which makes it allowable for them to receive the cutting-edge medications that they need.
I don't see any questions. Thank you for your presentation, and we appreciate your participating with us today.
Thank you.
Thank you. Are there any other questions for from any of the committee members? If so, what is the pleasure of the committee? We have a motion do pass. Is there a second? Second. Any other discussion from the committee? If not, all in favor say aye. Aye. Any opposed, no. Hearing none, the bill passes on to rules. Thank you, sir.
Thank you, committee.